Welcome, everybody. Welcome to the quarterly UP Network webinar. Today's session is called Delivering Culturally Confident Care, a 365 Approach. And we're so glad that you were able to join us today. And if you're joining us live or recorded, we thank you for taking time out to watch the recording. I'm Misty Kevich, and I'm one of the RN project coordinators. And today on our call, we also have Cindy Sun, Crystal Welsh, and Sharon Miller as RN project coordinators. And also part of our HHQI team, Misty Dyke and Andrea Lefke are also on the call today. So I do want to handle a couple items today before we jump right into our presentation. Please ask any questions that you may have throughout the course. Your phones are muted throughout the session, so we want you to use the Q&A or the chat feature to put your questions. We are going to use the chat box several times today during this session, so we do want to make sure you open your chat box up, look for the bubble on the right side. We're going to have several polling questions, and so we're going to want your choices to go into, or your answers to go into the chat feature. Also, there is going to be a short video that we're going to have you watch during the presentation. Unfortunately, the WebEx player does not incorporate video very well. So what we will do when it's time to do that, we will put a link within the chat box that you're going to be able to click on. And even if you're watching the recording, you still will be able to click on the link that's in the chat box, and it will take you to watch a short video, a little over 2.5 minutes. It'll be quiet on our aspect while you're watching it, but we'll give you about 3 minutes and then we'll come right back to the presentation. But do watch the chat box because we're going to ask for some of your feedback after watching the video as well. And obviously, if you have any other questions or comments, do keep them coming throughout with the Q&A box throughout. So with that, we'll go to the next slide. And I'm excited to introduce our presenter today. This is Miss M.A. Bong, or as she is known as M.A. Martin, and she is a passionate and expert in improving health for disadvantaged and underserved communities. We were fortunate to have her present several years ago for us, and we're thrilled to have her back. She has over a decade of experience in addressing health disparities and achieving health equity. Ms. Martin manages the cultural competency activities of Adventist Healthcare in Suburban, Washington, D.C., and she lends her health equity expertise as a consultant to various organizations. A particular passion of Ms. Martin's is improving the health outcomes for African immigrant communities, as she is the daughter of 2 West African immigrants to the United States. During her tenure with Adventist Healthcare, she successfully managed a 2-year innovation program called Project Beat It, Becoming Empowered Africans through improved treatment of diabetes, hepatitis B, and HIV/AIDS, and that addressed the cultural needs of those African immigrant patients living in the United States and educating providers on culturally appropriate care for that population. She has earned her master's in public health and behavioral science and health education from St. Louis University in St. Louis, Missouri, and a bachelor's in biochemistry from Brigham Young University in Utah. MA is the recipient of the inaugural National Minority Quality Forum's 40 Under 40 Leaders in Health Award. So with that, I'm going to turn over the presentation to Emmy.
Good afternoon, and good morning to my West Coast friends. Thank you so much for that generous introduction, Misty. I'm excited for this opportunity to speak with you this afternoon or this morning about culturally confident care. And there is an intention in using the word confident because truly becoming culturally confident or culturally competent is a journey. And so I feel that stating cultural confidence reflects the journey rather than the destination of delivering culturally appropriate care. One of the things that Misty and I talked about as we thought about having this conversation, about having this presentation, is the idea that often as we think about patient-centered initiatives, as we think about cultural competence or cultural competence, we often discuss them as just that, as initiatives, as another box to check, as another new hot requirement of something to complete in our many requirements of things to do every day. And so I would argue with you that rather than thinking of cultural competence or cultural competence as a check mark, but that you really consider it as integral and not interruptive to what you're doing in delivering culturally competent care and into the total patient care continuum for the communities that you're serving. For today's presentation, there are several objectives that I wanted to focus on, the first being the business case for why it's important to deliver culturally competent care. Second, discussing the changing demographics of the United States and looking at cultural diversity and health disparities within the context of those changing demographics. I'll also discuss beliefs, biases, and assumptions, our personal beliefs, biases, and assumptions, and how those things influence our patient care delivery. And lastly, we'll talk about some strategies for effectively communicating in cross-cultural situations. So what is the business of cultural competence? Why is it important? First, we have a very diverse melting pot in the United States. You don't need me here to tell you that. In any of the communities in which you work and serve, I'm sure that you can bear your own testimony of that. And as we continue to change and become a cultural melting pot, as we're projecting that by the year 2030 we'll become a majority minority country, or rather the year 2044 by the U.S. Census that is predicted, we'll see how much more diverse we become and how that will shape our patient care delivery. Reducing healthcare costs is key in being culturally competent. When we are culturally appropriate and meeting the needs of our patients individually, we can reduce medical errors. When we understand the first time what they are expecting, be it through a medical interpreter or through a cultural nuance that they're articulating, we can reduce unnecessary exams and save costs that way. When the first time they present themselves, we're able to quickly identify what tests are required and what's not. We often talk about our friendly faces or our readmissions that continue to come back through the doors. And if we're culturally appropriate in meeting their needs, then we're able to assess what their challenges are, why they're not being compliant. Perhaps we're asking them to somehow violate something that's really important to them in prescribing to a certain regimen. And so we have a conversation and understand why they're being compliant or not compliant, or what we can do to still achieve the desired results. Then we can avoid those readmissions and seeing those friendly faces back in our EDs and our healthcare settings. So for years ago,
Emmy, I'm sorry,
yeah.
Emmy, this is Misty. Sorry to interrupt, but could you adjust either your headset or your phone a little bit? Sounds you're a little distant, and we don't want to miss a word you have to say.
No problem. Thank you for the interruption. Is this a little better?
It is definitely better.
Okay. Let me see if I can make another adjustment.
Sorry, and you sounded fine in the pre-conference, but we don't want to miss anything you're saying.
No worries. Is this better? Yes.
Much better, much better. Thank you.
No problem. Thank you for bringing that to my attention, and I regret if anyone missed anything that was said. I'll just briefly, again, touch on the point that in the United States, we have a very diverse melting pot, and it's only going to become increasingly more so as we approach 2044, when the U.S. Census predicts that we'll become a majority minority country, meaning that those who identify as non-Hispanic white will be representing more than 50% of our population. Thinking about reducing healthcare costs, a great study published by the Joint Center for Political and Economic Studies in 2009 reports that almost $230 billion with a B, $230 billion could be saved over a 4-year period if we were culturally appropriate, if we were culturally competent in the way we deliver health care. That's a pretty significant finding, and one that every CFO would want to tap into. How can I avoid that part of loss that I own in my healthcare system? And so there's definitely an impetus to be culturally competent. financially speaking. From a rules and regulations perspective, the CLAS Standards, the Culturally and Linguistically Appropriate Service Standards, instituted by the U.S. Department of Health and Human Services in 2000, speaks to the fact that anyone entering a healthcare system in the United States should receive care that is culturally appropriate, that meets the needs and is respectful of the patients that they serve. And I'll talk a bit more about those CLAS standards in the upcoming slide. The Joint Commission also speaks to and has a roadmap that indicates how we can deliver culturally competent care from admission through discharge, and so it's a priority for them as well. And then Title VI in the law also states that discriminatory practices should not exist for anyone receiving federal funding in a healthcare system, and as providers and recipients of CMS, most of our healthcare systems, if not all of them, certainly fall under that regulation. And then in the healthcare reform, several years ago under Obamacare, we have several linguistic and cultural access provisions that encourage being culturally competent around providing linguistic access services and training around what it means to be a culturally competent provider. To briefly touch on the CLAS standards, which some of you may or may not be familiar with, there are 3 sections under which these standards fall, the principal standard being that we are to provide effective, equitable, respectable care, and quality care that respects and acknowledges the cultural beliefs of our patients coming through the doors. And we do that within these 3 sections of governance, leadership, and workforce, communication and language assistance, such as interpreter services. Thinking about governance and leadership and workforce, what are we providing in terms of training? And then engagement and continuous improvement and accountability. How are we checking up and assessing that what we're doing is actually effective? Thinking about the CLAS standards, there are many benefits to implementing those standards. There's a cost savings perspective around shorter stays. If we're able to make sure that we speak the same language as our patients or that we're providing interpreters who do, then that's going to increase our market share with that community as they continue to come back to the door and they tell their communities to do so as well. We increase provider and patient satisfaction when we're able to understand each other and able to deliver care that's culturally appropriate. Both are happy. Both patient and provider walk away from the encounter thrilled about the experience that they're having and wanting to return for more as necessary. We use our time effectively when we have interpreters present the first time, as opposed to trying to use our high school Spanish or French to communicate. When we're able to use our time effectively by preparing and knowing that language services may be needed, understanding that our patients need a certain service, then that will also be a cost savings. We also are able to discharge people correctly the first time and, of course, save money from that. If any of you have any questions at this time, I encourage you, of course, to use the chat box to offer those up. In the interim, I will proceed to just briefly talking about the first piece that I mentioned under the cost savings piece of being culturally competent in this business case, and reviewing briefly how our demographics in the U.S. has changed over time. In 2002, the U.S. Census published a report, a special report on the demographic trends over the last century, and they did so by U.S. region. And so I'll briefly take a look at several of these figures that I borrowed from them that speak to how the U.S. has changed in terms of race and ethnicity. And so as noted in the chart, these categories represent non-Hispanic white populations in the U.S. And we see that over time, approaching the turn of the century, there's an increasing representation of races and populations, and including multiracial persons. This first indicates the Northeast region and how that's changed over the 100-year period of 1900 to 2000. I'll move forward and show you the Midwest, which also shows a similar trend of how there's been an increase in populations that are of racial and ethnic diversity. The Southern region, of course, a large overrepresentation of African Americans or Blacks in the South per the U.S. history of slavery in this country, and how that's continued to pretty much, while it's definitely seen a bit of a decline, there has continued to remain diversity and an increase of diversity in other populations as well. And then lastly, in the West, we see how they represent the part of the United States that increased in the most amount of 2 or more race persons living in the West. And we see that over time as well, they have represented a great amount of diversity similar to the rest of the nation. And so as we see that over the last century, this increased diversity of races throughout the United States reflects, again, the same things I'm sure you're seeing in your communities, that we are becoming a melting pot and have become so as time has progressed and will only continue to become so. I want to take a moment to just hone in on the Washington, D.C. area where I am based and take a look at some demographics based on the last U.S. Census in 2010. An interesting thing to outline for you. So Montgomery County, Prince George's County, and Frederick County are all Maryland-based counties. Montgomery County, Maryland, sitting on the northwest region of the District of Columbia. Prince George's County sitting on the northeast region of the District of Columbia, and then Frederick County sitting just right above Montgomery County. An interesting observation for Montgomery County is that during the 2010 census, they saw a very unique historical watershed moment in that they became, for the first time, a majority-minority county, where non-Hispanic white persons represented less than 50% of the county residents. A pretty big deal for a county that over time has continued to shift towards more racial and ethnic diversity, and for the first time actually achieved that. Also of note is in these counties, the foreign-born populations almost represent 10 in one of the least diverse counties of the three, Frederick County, and then approaches almost 33% in Montgomery County. And so that is an interesting fact to observe for the state as well, that diversity in foreign-born persons is also represented and overrepresented actually compared to the United States standard of 13.1. Also of note is that languages other than English spoken at home are also in the double-digit range and approaching or exceeding the U.S. standard of 20%. Montgomery County is, again, one becoming a very diverse county. In fact, again, it has exceeded becoming what you could call diverse, as they've exceeded the 50% point. And almost 40% of its residents during the 2010 census spoke a language other than English at home. And so, again, as we see that compared to the United States, which is 20%, a fifth of the population, that's a pretty big deal. And as we think about how those demographics will continue to shift towards more diversity, towards more languages, it then begs questions for how do we meet the needs of these populations that are coming through our doors. And we'll talk more about that shortly. But in the interim, I first wanted to take a look at ourselves as far as diversity is concerned. This diversity wheel by no means represents every aspect in which we are diverse, but diversity comes in many shades, many colors, no puns intended, but in terms of many levels and different aspects in which diversity can be represented. Starting with the outermost portion of this diversity wheel, the organizational dimensions, where we work, what departments we work in and who we work with, and where our work is located, those things are fluid and can change rather quickly or rather fluidly throughout our lives. Perhaps we get a raise tomorrow, perhaps we get a new job tomorrow. Coming closer into the external dimensions, those things are a little less fluid than the organizational dimensions, in that our parental status certainly can change and does change over time, as well as our marital status and our income, but perhaps our faith is something that becomes a bit more rigid for us as far as religion or work experience. As that changes, that also may start to level off as well. And then lastly, we come into the internal dimensions, our age, our race, our gender, our ethnicity. Those things tend to be a little less rigid even still than the things in the external and even the organizational dimension. As we move forward through life, some things flow and ebb, and some things not so much. But of note, depending on where you are in life, depending on what's going on in your life, these pieces of diversity will speak to you more so than at other times. And so I'd invite you to take a moment to look at this wheel And consider it for yourself today, Thursday, July 21st, 2016, depending on what's going on in your life, what's most relevant to you. Take a moment to consider 2 or 3 pieces of this diversity wheel. It can be on any level. They can be on the same level. And decide what for you is most important, what is most definitive to who you are today. If you were to meet someone for the first time, introduce yourself, how would you define yourself as what is most significant to you? And place that in the chat box. Excellent. Thanks for your participation. I'm starting to see some feedback. People have said educational background, their ethnicity, and their race are important to one, age, personality. Great feedback. Thank you for participating. One of the things that many may notice in their lives is that while there are many things that we can see at the surface, our age, our race, our ethnicity, there are so many things that are so much more critical and integral to who we are, such as our parental status, our behaviors, our marital status, sexual orientation, our SES. So many other pieces of who we really are the things that are below the surface that people can't see immediately, but yet they make assumptions and judgments on the things that are above the surface, that are above the line. And so this theory of the iceberg is one that throughout our lives, we all do this. We all make assumptions. We all have our quick judgments that we make with people and that in turn people make with us. And they tend to be more surface level, whereas the things that are most integral to who we are, that really make up the bulk of who we are the things that are non-visible and below the surface. And so as we consider that in our patient care, as we consider that in our relationships, both professional and personal, how do those things interplay? How do they affect how we treat others, what we think of others? I encourage you to give that some thought as we continue this conversation and how perhaps in your realm of experience, in your realm of influence, you can use this iceberg theory as a stepping stone and not a stumbling block in your relationships and in your care delivery. So diversity. Diversity is a big umbrella for many things. There are differences among people likely to affect performance, satisfaction, and progress. And there are many different elements of diversity we just saw on the diversity wheel. Things that we can see, things that we can't, and they fall within a wide spectrum. And so considering this definition of diversity, one of many, I would ask for your feedback on what are some of the challenges of work and benefits of working and living in diverse communities. If you'll offer some feedback in the chat box, we'll give you a few moments to do that.
May, this is Misty D. I'm going to jump in here real quick. It looks like we're getting a lot of feedback here in the chat. Love to see that. However, it looks like folks are sending it just to me privately. So if you can, before you submit your chat comments, please select either all panelists or all participants from that drop-down menu there before sending, and then that way we can all see your comments. Thank you.
Thank you so much, Misty D. I was thinking we've got a silent room here. What's going on? Good to know that we've got a private room, apparently.
Yeah.
Thank you. So I do see a benefit, it enriches one's life. A challenge, communication. I noticed that from a few people, the communication challenges. Benefits, we're able to tap into a wide variety of viewpoints. Absolutely, you guys are right on. I'm also seeing communication come a lot. Equity for all, benefits, variety. Another benefit, high quality of understanding and acceptance. Thank you. These are all great feedback and right on. I'll just go through a brief list of some ideas that have come to my mind. So some challenges, misunderstandings, misperceptions. I think we all can agree and have seen that challenge happen in our lives when we have a certain way of thinking and we assume that, of course, you have my way of thinking too, right? And unfortunately, we don't always meet in the middle, and so that challenge can definitely affect how we interact with people. As you all stated many times, communication barriers that can be both language as well as, again, the misunderstandings that we can encounter. Group conflict, this idea that maybe as I start to find a home with those who are of similar mind, that causes tension with another group that isn't of the same like mind. And so that can interplay with how we, as a team, as we try to be unified, deliver or don't deliver great care, or interact and get along or don't get along in our team or our department setting. Exclusionary behavior, perhaps because I don't see you as the same, because I see you as someone who's just so different from me, I start to conglomerate and work with those who I think are more like-minded. Maybe it's intentional, maybe it's malicious, maybe it's not. But in some way, somehow, I exclude you from the conversation. Cultural differences, pretty self-explanatory, but the idea that culture, whether it's a geographic culture of where I was born throughout the world, or that's a geographic culture difference in that I was born on the West Coast and you were born on the East Coast, and we have some differences in how we view the world that way, but those can definitely present challenges. We can easily make stereotypes, make judgments without having the full picture, and again, that kind of speaks to the iceberg theory that we just discussed. Diverse opinions and the way we think and work. Maybe I approach this tool one way and you approach it another way. And they're both great ways, but they're different. And so as we do that, maybe we have a butting of heads. Maybe there's some misunderstanding. As far as benefits are concerned, interestingly enough, diverse opinions and work styles is also a benefit. While it can be a challenge, as we come together and have different ideas, that can help us be stronger, as I'm able to look at your perspective, one that maybe I never considered, and use that to benefit the group and the process overall. You have personal growth. One of you mentioned that you get to learn a lot about other people. You get to benefit from the understanding of different opinions. There's a lot of talent that you can find in diversity of opinions, a lot of great ideas and ways of approaching things. And again, the sum is a total of the parts. And so we bring these different parts together and make for better. Great ideas as well that come to the table, that are innovative, that are different from your own. It's always good to have someone who can look through the same glass but see things differently. Lots of creative solutions, similar idea, and the opportunity to create more inclusive culture as you think about the ways that we can bring these varying ideas together and learn and grow from them. Higher productivity, as you, again, come together with these great solutions, creative ideas, you only are going to hopefully achieve better together with these varying opinions. And as a result, be a better organization that's valued and appreciated by those who you're serving. So the challenges and benefits of diversity, they exist. But overall, we can take those challenges and create them into benefits and opportunities for improvement, opportunities for growth. And so in view of that, we know that there are challenges, there are differences in the health outcomes that our patients experience because they are different. They're different people with different experiences, and without malicious intent, I like to believe, as they come into our system, they don't always receive the same care or have the same outcomes as we desire and as we hope, as we're striving to give them the best quality care, because somehow there's some things that are missing. There's some opportunities for us to improve and give care that's more patient-centered. And so health disparities occur when somehow those gaps exist, when we don't meet every patient exactly where they're at. And they can exist in many different ways. They can be as far as social disparities can exist, demographic based on where you live and the challenges that you have as far as access to treatment or care. Environmental, again, is perhaps you live in a place that is disproportionately polluted or doesn't have the structures in place for you to actually achieve your optimal health. Those things can occur. And so as we think about health disparities, specifically, we know that racial and ethnic minorities, for instance, that's one category where health disparities can exist. And in the landmark IOM report, the Institute of Medicine in 2003, they published findings that observed that even when all other things are equal, minorities, unfortunately, can receive and do receive a lower quality of care in some cases, such that their outcomes produce disparities. And so when we think about that, how then do we work to make sure that we can meet the needs of our culturally diverse population? How do we make sure that we are not perpetuating disparities when we realize that this is an opportunity where this can occur? There are many reasons why health disparities exist, and I'll just briefly go over some of these highlights. Again, we mentioned socioeconomics, income and race and age. Those things can impact how I receive care. If I have access to insurance, if I am older and maybe are not seeking health care, or similarly if I'm younger and not seeking health care, that can cause a disparity to exist. And again, that also speaks to the next point about health-seeking behaviors. Perhaps if I'm young and invincible, I don't seek health care or preventative services until it's too late. Where I live and where I work, those things can certainly influence what I'm exposed to and how that impacts my health outcomes. Whether I understand and appreciate health care and have a knowledge of what it means to be healthy. Our differences in the quality of care. Perhaps I live in a neighborhood where I only have access to FQHCs and not to a research institution or a university center. That can also impact how I receive care and if a disparity may perpetuate and exist there. Whether I have access to health care that is comprehensive can also influence and create health disparities. And whether I have exposures that are inherent to where I live or where I work can also produce disparities for some people. And so how then do we overcome these many different contributing factors to disparities? We can't save the world, of course. We can't completely build a new Rome, if you will, in a day. But there are some steps, there are some ways that we can approach our delivery of care to make sure that we are doing our best to not perpetuate health disparities in the system. These two definitions of cultural competence, I think, really touch on how culturally competent care is really a journey and also a process that involves not just the one-on-one interactions, but the organizational perspective. Cultural competence is a great way to look through the lens of the delivery of care and make sure that in our sphere of influence, we are doing our best to not perpetuate or create disparities. On the left, the practitioner's guide, a definition speaks to the idea that we acknowledge and understand diversity in the clinical setting. We're respectful. We understand the health beliefs and practices of our patients, and we do what is necessary to deliver care that is appreciative of that patient and the beliefs that they're bringing to the table. And when I do that in a one-on-one patient-to-provider interaction, then hopefully I'm doing my best to deliver culturally competent care. It's helpful if I work in a place that encourages me to do so. And so the organizational application speaks to the attitudes, the beliefs, the policies. And so not just is it written, but what is the vibe, if you will? What is the attitude of the organization that encourages me to be culturally competent? And so if I work in a place that encourages that, then hopefully I can be the person that delivers that care. And the spectrum, again, is really one that it's a daily step. It's not something that we arrive at overnight. It's ever to say that I have a checklist in the box being culturally competent. I have arrived. I really do believe it is a journey, and it's a journey that is achieved in congruence both with the providers of care and congruence with their organizations. There are many benefits, of course, to being culturally competent, as we've talked about already, the idea that we eliminate disparities and improve health outcomes, and the idea that we're able to do that as we help people to be more compliant, as they understand the first time what we're asking of them, and as we ask it of them, we do so in a culturally appropriate manner, and we make sure that they have what they need to go back and implement those strategies, be it in their language of service, be it in something that's culturally appropriate or respectful of their beliefs. Whatever that looks like, we can encourage them to be adherent when we're delivering care that is culturally appropriate. We enhance the quality of care when we are able to deliver it in a manner that, again, is respectful of the patient, that the patient understands, that the patient appreciates. Everyone is happy, both patient and provider, when we deliver care that is culturally competent. And it's most effective. It's effective in time, but most importantly, especially for our CFOs, of course, is effective in cost. And so the ripple effects are ongoing for culturally competent care. And so how do we get there? How do we begin to actually deliver care that is culturally appropriate? We first have to address and be aware of how our beliefs, our biases and assumptions are coming to the table and how they impact the care that we are providing. And so as we consider ourselves in the middle of this dynamic between our coworkers, our families, and the communities that come in to support the patients that we provide care for, as well as the providers of care, then we're able to step back and do a bit of reflection and consider that as I interact with these various communities, with these various audiences, they are going to influence how I am perceived and how I then am able to take my skills and deliver them in a way that is culturally appropriate. And it's important to step back and recognize that these interactions, different as they are, all have the underlying assumption, if you will, that I want to be a culturally competent person, a culturally confident person that is a good coworker, that's a good provider of care, that can give patients and their families what they need in the healthcare setting. And so at this time, I wanted to take a look at a video that was produced several years ago that speaks to this idea of kind of walking in another's shoes and being respectful of where people are coming from to kind of help reduce our biases. And so with that, I'll allow Misty to go ahead and encourage that viewing.
Go ahead, I have put the link into the chat box, and go ahead and click on it, and we'll be silent for about 3 minutes while you have a chance to review the video.
I hope everyone was able to enjoy that video. I'll ask you to take a moment or two to place in the general chat box any thoughts or impressions that came to your mind as you viewed that YouTube video from the Cleveland Clinic. I'm seeing some chats come in. Thank you for your participation. One person mentioned that it helped them to practice mindfulness, the importance of doing so. Another mentioned seeing the perspective of the patients and the families and visitors. One is mentioning that this was impactful, that they've seen this before, and it strikes a chord every time. And I, too, have seen this a number of times, and it really gives you a moment to take an introspective view and really consider how you influence those around you, how your attitudes, your assumptions can impact others. Little do we know the shoes that people are walking in, and yet, going back several slides to this iceberg theory, we make so many judgments on what's at the tip of the iceberg, and yet so little of who we are, what we're experiencing, what we have experienced is at the tip, is at the surface, is visible. And so as we think about that in this journey to cultural confidence, to being a culturally confident care provider, it's important to remember that indeed we come with a set of beliefs and practices, and so do our patients, so do their families. And those influences of their beliefs, their practices, what they value are influenced by a number of things: who they are in terms of gender, their socioeconomic status, what it was, what it is currently, whether they're U.S. born or an immigrant, and any challenges that may be associated with that, their age, and where and how they grew up, and how that influences their beliefs. As we especially come into a time where our baby boomers, if you will, are making a significant influence on our healthcare system, important to think about where they're coming from and what their thoughts are and what influences them. And then, of course, our faith beliefs, our religious beliefs and practices are going to influence how we interplay with the healthcare system. If we are health-seeking, if we believe in the health care that you're prescribing, maybe I have a set of beliefs that has a whole different value in view of healthcare delivery. And so all of these things impact who we are, who our patients are. And so both us, as well as our providers of care, as well as our patients, are coming to the door with these varying beliefs and practices. We are coming with these different sets of values. And how then do we bridge the gap between what I believe, what I value, and what you believe and what you value in order to communicate effectively, to care effectively, to be culturally confident? I suggest that there is a great strategy called the LEARN model for being cross-culturally communicative in an effective strategy. And this LEARN model is one that is an acronym for first, listen. Listening with sympathy and understanding to a person's perception of the problem. And we all have been passive listeners. Some of you may be passive listening right now, no offense. But when you listen with sympathy, when you listen with understanding, that changes the perspective, that changes how we interact. It takes on a new meaning as far as how we're going to deliver care. We then, moving into the next acronym, piece of the acronym, explaining your perception of the problem. How do you view the problem? How does your patient view the problem? Acknowledging that you may have two different perspectives, and then looking at how you can recommend an action plan in view of those perspectives, and then negotiating between the two perspectives that you have. And so a great application of this model, one of the things, as Ms. D mentioned in my introduction, a passion of mine is working with African immigrants and improving their health outcomes here in the U.S. And one, and by no means, as we talk about cultural confidence and cultural competence, don't want to stereotype, but in many West African cultures in particular, there are ideas that some health beliefs, there are some health diseases that may be caused by a hex or voodoo or a curse. And so thinking about that in the context of this learned model, perhaps you have a patient who comes in and says, I've had this throbbing headache for 3 weeks. I don't know why, but I think it might be a curse that my neighbor back home in West Africa placed on me. That's where I think the nature of this curse is. And so as you listen to this story, this background that this patient's sharing with you, it may be in our Western culture that we might want to just laugh out loud. That sounds preposterous. Why would that ever be the case? But the learned model encourages you to listen with a sympathetic ear. Maybe you've never heard of such a thing before as a provider, but you're going to take this opportunity to let them educate you about why they think this headache has come about this way. Then you'll explain, well, as you've mentioned some other things in your life in addition to this neighbor who has this disdain for you back home in your home country, you've also mentioned you've been under a lot of stress. You've also had, a good friend pass away, or you've had some challenges with your teenage daughter. Perhaps those things are also contributing to these major headaches. So acknowledging that not only do you have a perception that's different from theirs, but not dismissing their perception as well, acknowledging that perhaps in addition to what their concern is, that there may be some other contributing factors. And then in view of that, recommending an action plan. Perhaps for them, they think that in order to get rid of this curse, I've got to do a reverse curse to get rid of this headache. And so not dismissing that, encouraging them to do that, as well as perhaps take this medication or also see a therapist for the other challenges that you think are contributing to the headache. And then together, deciding what that action plan will be and how you'll follow up and determine how that action plan is met and how, if any, progress is made as you've implemented it. And so as we think about the learned model and think about ways of communicating with people with different backgrounds, be they, again, foreign-born or not, you can have cross-cultural challenges with your spouse, with your significant other, with your children. I'm sure many of you could share stories in the chat box all day about that. But whatever that culture is, again, understanding that culture is so much deeper than a country of origin or place of birth, but it's the experiences that shape who we are that can present these challenges in communication. And so as we think about that, as we try to honor and respect where people are coming from, also understanding that we, too, are coming to the table with our own set of beliefs and biases and assumptions, then hopefully the learned model is an approach that you can use to help you effectively communicate and understand and achieve cultural confidence in your settings and your patient-provider relationships. Because truly, every encounter is a cross-cultural encounter, whether I'm dealing with my twin brother or sister, or my child, or someone who was born 5,000 miles away from me on in another country. Every encounter that we have is an opportunity for us to learn and grow from one another and to become a more culturally confident individual and more culturally competent provider. And so as a wrap-up, these are a few keys to success that I would want to leave with you. One, become familiar with the cost benefits, the business case of why it's important to deliver culturally competent care. It makes dollars and cents. It saves dollars and cents to be culturally competent, in how we approach our policies, in our care, in our systems. And so understand that and be able to communicate that with your peers, with your colleagues, as an encouragement to be more aware, to incorporate trainings, and to be on board with being culturally confident in all of your practices. Understand your specific demographics in your communities of care. As I did show, we, of course, as a nation are moving towards culturally diverse neighborhoods and communities, but every community is different. Perhaps as you're moving towards diversity, you're seeing more of a Native American population than other parts of the U.S., or more of an older population for whatever reason. And so as you acknowledge and understand that and collect your data, make sure that you're able to be responsive and attentive to the needs of the diverse communities that you are serving, because it's not necessary that you could copy and paste from another institution who may not have the same demographic makeup. And so make sure that you're understanding what your unique needs are in your system. Acknowledge that you have your own cultural beliefs and biases, your own values and assumptions. And as you understand that, then you can be more aware of how they influence your interactions with others. Accepting that others too have their own cultural beliefs, their own practices, and that's okay. That's what makes the rich melting pot that is this country, that is this life experience, as we get to know others and have every encounter be a cross-cultural encounter where we're doing our best to be our best and hopefully seeing others in their best light as well. And so with that, I'll open it up to you all for questions or for comments along these lines of how to be more culturally confident in our practices.
Sorry, Emmy, this is Misty. I couldn't find my mute button either. So if you do have questions or even comments that you want to provide, go ahead and put it in either to the chat window or the Q&A, and we'll address as many as we have. Currently, there are none unless there has some been sent to Misty Dyke personally. We'll kind of wait a few minutes. And actually, Emmy, if you'll go ahead and we'll cover a couple resource slides while we wait for some to come in. And thank you so much. The information you have provided has been wonderful information, practical information, and really painting the picture for us.
Well, thank you. Certainly, certainly.
Good. I'll just go ahead and have you change a couple slides here while we wait on some questions. And in the meantime, I did put in the chat box a link that takes you to a previous webinar that Emmy did for us on reducing health disparities through organizational cultural competence. I think it's excellent, and it will give you more insight from that perspective. And so it was from 2013, but I did provide the link and you would be able to find that information. We also have an underserved population best practice intervention package, or BPIP, that provides other cultural competency tools and resources. I have those listed on the slide, and specific page numbering for those areas that you'd be able to locate very easy from the BPIP. The next slide, please. Just as a heads up for the next quarterly Up Network event, it is October. That seems so far away, but October the 20th at 2 p.m. Eastern Time. You can click on the Register Now link that's on this site or on our Up site and register ahead of time. It is all about you. Home Health Agency is going to be talking. They recently, literally, just we wrote a success story about them called A Patient-Centered Approach to Home Care, and it was in the Fundamentals of Reducing Hospitalization BPIP that just went live the beginning of this month. And there is a link just to the success story as well as the BPIP. Next slide, please. And I'm going to go over the continuing education for today's session. We do have 1.25 hours of nursing CEs that are approved from the Alabama Association for Home Care, which is an NCC, so appropriate for all the states. The requirements were to watch the webinar, which you did already, and so I'm going to give you instructions how to do the rest of the pieces in the HHQI University on the next slide. So you've completed one portion, but there is 15 minutes, just very quick, to complete an evaluation and reflective questions to finish, and then you'll be able to download and print your certificate. And if you have any issues whatsoever, please contact us at hhqi@wvmi.org. Next slide. Now, we are breaking this down by, it seems like it's complex, and thanks to my colleague Cindy, who really pointed that out to me yesterday. It is really simple. If you've not used our HHQI University before, it is very user-friendly, but we've had questions from different people, so we broke it down into pieces so that you can see exactly what you need to do. You will need to register in HHQI University if you have never taken a course in the university. It's free. The registration's like 4 questions. But if you think you've registered, do the I forgot my password feature and see if you get it, because you don't want to have a duplicate. You want to keep everything in one file. So you're going to be redirected to that site after this webinar anyway. So go ahead and click on next, please. The next slide. And the second piece is you will need to go into the course catalog, and you will look for the Quality Improvement course catalog, and you'll find the course Delivering Culturally Competent Care, and click on the little apple to enroll. And then you click on My Account, because that shows what you've enrolled in. Click the little green button, or a box, which looks like a book, and it'll take you to the View screen. Next slide, please. Click again on a green book, and it will start your course. There is only one lesson in the course. There is no post-test. So if you've taken courses with us before, you might have had 2 lessons because there was a post-test and then the evaluation was separate. So basically, it's just to go to the web, to HHQI University, log in, go to Quality Improvement Catalog, go ahead and register with the little apple, click the 2 green books, and your course will start. Now, you're not going to hear this course over. It's basically going to say that you needed to complete this and then do the evaluation. That's it. Once you've completed the evaluation, it'll tell you to click the exit button, and it'll come out. Your certificate will already be there in your My Accounts tab on the left side. If you have any trouble, contact us through the mailbox, and we'd be happy to get that for you. Next slide. And that's just our contact information, and I'm not seeing any questions. Misty Doug, do you see anything that I might be missing? Oh, here we come some.
Yeah, we got a couple coming in there.
All right, Emmy, how do you help a culturally different person recognize they also need to recognize others have different views that are not wrong? That can be very frustrating.
That can be very frustrating. That's a great question. I think the challenge there is for us can be that we have to recognize there's only one person in that equation that we have control over, and that's us. And so as we model an attitude of understanding, as we model an attitude of empathy and cultural confidence, people tend to pick up on the social cues, most often than not, right? People will adjust accordingly when they see that, you know, this person's not really supporting my ideas. They're not really supporting this idea that I'm going to just be in my own world, in my own biases, and live there and be okay with that. Once they see that inclusive nature, once they hear that, then people start to back off of their defenses and start to maybe listen up a little bit. It doesn't happen overnight. Sometimes there are those light bulb moments, but I think as we model the appropriate attitude, that helps people to start to get on board, if you will.
And we have one, I'm sorry, and we have one more, and that's all we're going to have time for. I know we're at the top of the hour, but I wonder what activities besides the presentation might help practitioners face their biases with delivering care.
Sure. So a couple quick ideas. One, Harvard has a great online tool. It's an implicit bias test. It's individual. Everyone can just kind of get onto their own personal computer and take it. And it gives you an opportunity to see some images and with pretty rapid fire response give your feedback. And that's a personal opportunity for each of us to look at what are my biases, what are my assumptions, and where are some opportunities for me to improve. I also think more powerful than this presentation is a live in-person trainings that can be very effective and helpful. And it is not the Stanford, it's the Harvard implicit bias test. Google it, it's a pretty easy find.
Great. And you said Harvard, correct?
Correct.
Okay.
Wonderful. And in-person trainings you can do certainly. I know I can speak for myself. We certainly contract with organizations to bring those to you, but the in-person conversation and training is always an effective way to do that, to get those biases and assumptions discussed and addressed.
Very good. All right, I know we're at the top of the hour. We thank you again very much, Emmy, for presenting to us today the great information. And we hope that each of you are able to take some things back with you to be able to incorporate into the work that you're doing and continue to learn and research more on this avenue and share with others. So we thank you again for attending today's session.